Good morning. Welcome to Grand Rounds, April 9th. We are thrilled today to have Professor Joel Yager from the University of Colorado here. Joel is my good friend and the mentor to many of us. Before he was at Colorado, he's now an emeritus professor at the University of New Mexico, and more importantly, an emeritus professor from here. Joel started off in the Bronx, went to the High School of Music and Art, so he should have ended up being on the Borscht Belt instead of in psychiatry, college at CCNY, and then med school and residency at Einstein. That's the background. The important part of the story starts in 1973, when at the tender age of 32, Joel Yager comes here to be our residency director, where he stayed for 22 years, from 73 to 95. During that time, he trained a surprising and maybe even depressing number of the current senior faculty, including myself, Andy Luchter, Tom Strauss, Ken Wells, Bruce Kagan, Joel Braslow, and yea Lord, even Jim Spar was trained by Joel Yager.
You can't win them all.
Right, you do the best you can with the material you have. Other people who he's trained have become department chairs, multiple department chairs, and even one medical school dean is a former resident of Joel's. Without doubt, from maybe early 80s to mid 90s, Joel was really the preeminent psychiatric educator in the United States. He was the president of the AADPRT, whatever that residency director acronym is, and he was really the guy in the United States in terms of psychiatric education. Also in the 1980s, he started to develop an interest in eating disorders, topic for today, and he started our eating disorders program here in the early 80s that he ran with Carol Edelstein for years, etc. And then eventually, unfortunately, that clinic is no longer with us, but he made this place really a national place for eating disorders interest, and of course he has been an international expert on eating disorders during that time. For the last 10 years in Colorado, he works what Joel thinks of as part-time, which is far more than most of us do full-time. He's running endless DSM-5 committees, running the practice guidelines committees for the DSM. He has published over 300 papers. He's edited 8 books. He has been on the editorial board of every major journal that we have, including the American Journal and what is now called JAMA Psychiatry. All right, so that's the official stuff. So on a more personal level, Joel has been a mentor to many of us. Certainly for me, he has been the most important mentor in my professional life, maybe in my life. He has, as those of us who know him, boundless energy and good cheer for almost everything. He is brilliant, and his intellectual curiosity about everything is apparent in every interaction, and sometimes a little overwhelming. He seems to have read everything in psychiatry, knows everything, and remembers all of that, which is shocking. His passion for this is still there seemingly after 50 years. And when I was interviewing for the residency, low back in the early 70s somewhere, Joel seduced me with that intellectual curiosity. You just say, oh, hi, I was thinking of it. And he said, oh, let's do a literature review and write 4 papers about it. It was a little overwhelming, but it was seriously intoxicating. His passion for knowledge and for using knowledge to help patients has really been his calling card. And he works on the conviction that we need to know more, and the more we know, the better we're going to be as doctors to our patients. And I think that was one of the great messages and gifts that he gave both to me and to all of us who were trained by him. And so I am eternally grateful to him for that. Today, he's going to be talking about a very interesting and controversial area that involves end-of-life decisions for patients with eating disorders, something he has written about extensively just within the last year. So I'm thrilled to introduce Joel Yager.
Thank you. Is this on? Okay. So the first time I played this room was 1973. I had a 4-piece band. And countless opportunities to talk here. I was going to tell about Jim Spar being an obnoxious medical student. Nobody would believe that. And almost not getting into the residency. I look around here and there are so many people who are part of my heart. So thank you for being here, and it's really a lot of fun to be back. What I'm going to talk about today is actually beyond eating disorders. It started with eating disorders, but this is my new intellectual challenge for the day. Because my new best friends are 4 palliative care physicians who we started to play together around the care of patients with chronic, severe, enduring anorexia nervosa who sort of said, I'm done. And we've had it. But now we've opened that up to anybody who kind of says, I'm done. I've had it. People with psychiatric disorders of various kinds and people without psychiatric disorders, like people in the audience. So what I'm going to do today is provoke you and get you to reflect and mentalize about a bunch of things that we've been thinking about a little bit. So the disclaimer is, I'm conflicted about what I'm going to talk about, and my suspicion is that you are too. But I know that when you give a grand rounds, you have to start out by talking about your competing interests. So here are my competing interests in terms of work. Some of you, this picture is about a year old. In fact, Michael was there in Denver. So these guys are about a head taller now. But we have been blessed to have these wonderful, wonderful people in our life. Our kids are physicians. My son is a cardiologist who deals with end-of-life issues on a daily basis. And we talk about this all of the time. My son-in-law is a medicine professor who's chief of nephrology at our VA, and he's dealing with end-of-life issues every single day. So the kind of things that I'll be speaking about have become family discussions, and we all kind of put our heads around it a lot. So here's a trigger warning, and I'm serious here. If you have been recently dealing or are about to deal, or at some times in your life will deal with a death, this could be upsetting at some times in your life. And I have to give apologies. Those of you who know me know that I crack a joke once in a while. But I use humor to sort of deal with what is, for many people, existentially a really tough thing. So if you can't laugh at death, what can you laugh at? You have to think about this in a personal way. So let's get started here. Not everybody wants to think about their death, the death of those who are closest to them, the death of their patients, the death of their children. But life goes on, and you get a certain amount of toothpaste in your tube at the beginning, and by the time the years go on, you may get squeezed out. And this is great. If you don't believe that the only things that are inevitable are death and taxes, and they both hit you on the same day, you notice that Trump is fighting off his taxes right now. But okay, so here's the first question. How would you like to die? Think about it for a minute. Would you like to die suddenly in your sleep? One of my very good friends, dads, who is a professor of neurology, 3 weeks ago, sitting in his chair at home, 89 years old, he was just sitting there, and his wife and the cleaning lady thought he was just napping, but he just went out like that, kind of a blessing for him. Not clear if it was a blessing for his 95-year-old wife, who is having cognitive problems. You want to die someplace else? Would you like to be consciously aware of your process of dying? Some other way, and think about each of those things in terms of your own death and how that's likely to affect the people in your life who are closest to you. Say, I'd like to die like that, but boy, what's it going to do to my wife, to my kids, and so forth? When I die, I want to die like my grandfather who died peacefully in his sleep, not like the screaming like all of the passengers in his car. Okay. Beautiful, isn't it? So now let's do the next mentalization is, how would you like the person you're closest to die? We asked about you, now we ask about, could be your spouse, your partner, your child, so forth. Would you want them to die suddenly without any forewarning, or to be conscious and to kind of take it down the path? And how will you and others be impacted by their deaths? Everybody's going to deal with this at some point. And we never know quite how it's going to happen. This is from the High Holidays book, some by earthquake, some by fire. That sounds like Southern California, I don't know. Plague, stoning, we don't have that yet, and so forth. We just don't, you can't order off the menu. So these next cartoons were from an article in the Wall Street Journal, just showing how people die. You can hit the precipice, Niagara Falls, looping decline, up and down and up and down. You get a year, 6 months, and you kind of figure out that you're on the way out. Or the dwindles. The dwindles is a specialty that Gary Small has written about extensively, and he treats it with turmeric. Right? If I could, I would give you darts and you could kind of pick your own thing on the wheel of fortune here, or the wheel of misfortune, but this is how people die. You don't always have a choice in it, but Alzheimer's, assaults, cancers of a variety of flavors, fires, suicide, motor vehicle accidents, and so forth. And our good friend Ed Shneidman, who was on the faculty here, who was the first professor of thanatology, defined a good death in a very interesting article. The dying person is free from physical pain, dignified, lucid, graceful, attended by loved ones, amicability and love, flowers, pictures, music for the dying scene. It's a movie. Passed on the wisdom of the tribe. Everybody has come around, said, I love you, Dad, I love you, Mom. And you go out and everybody has it's kind of a celebration of life. If anybody wants a career opportunity, there's no epidemiology yet, to my knowledge, to let us know how frequently people actually die this way. It happens, but my suspicion is it's 10, 20% of the time, if we're lucky, because this is actually how people die. And this is an article on, from JAMA for 2009 on Medicare recipients and what happens in their death trajectory. And what happens is a lot of people, 2/3 of people are not dying at home. They're dying in hospitals, they're dying in hospice, they're dying in nursing care homes, and a lot of them are getting a ton of medical care, ICUs, ventilators, expensive care in those last couple of days and couple of weeks of life, and probably dying an undignified death in the course of that. If you want examples, there's something called the Ronald Reagan Hospital across the street. You can go there any day of the week and see more of this than you'd care to. Now, by doctors, we're talking about PhDs as well as MDs. How do doctors, how would you like to die? And there are studies. If you were getting sick and sick, would you want CPR, dialysis surgery, feeding, and all of those big things at the, from the left to the last one on the right, say, I don't want any of that. Doctors do not want extreme care. They do want pain medicine and palliative care. That's what's at the end. The right-hand column is take care of the pain, give me palliation, and keep the rest of the stuff. Very important. And this is from another physician's poll, and the question is, if you were faced with a terminal illness, what treatment options would you like? And most people say, I would like hospice and palliative care, please. And DNR, and extraordinary measures, 7%. Very small percentage of physicians who really want kind of gung-ho medicine when they are on the way out. Now, that's us. Guess what? Every one of our patients is dealing with the same thing, including our psychiatric patients. And the question is, do we have the wherewithal to treat our psychiatric patients with enough dignity to respect their end-of-life choices and decisions and not to call it suicidal? And that's really what this whole provocative question is about. At what point do you say, you know what, you're a human being, and if you've had enough and enough is enough, I respect that. So this is called the creation of the most personal of individual decisions, somebody on life support, and then you have these guys in the state with their legal things, and good to see you, Andy. Trying to figure out whether they're going to give the patient permission to turn the switch on or off. So now let me ask you this. Treating a variety of patients who have different levels of mental capacity, who has decisional capacity? Decisional capacity being the legal right to determine what they want. They want care, they don't want care. Let's say 90% of the people in this audience don't have a psychiatric disorder. I'm being generous. That's good. But what kind of psychiatric disorder can you have, or will you grant to somebody and say they are still decisionally capable? If somebody's depressed, can they make a decision for themselves? Whatever depression means, I mean, we know it's a garbage diagnosis. What about people who are psychotic, actually psychotic, hallucinating, delusional? Will they ever have the capacity? You know, I may be crazy, but I'm not stupid. And I know that I've been struggling with this. It isn't the voices that are telling me to kill myself. I've been around olanzapine, I've been around TMS, you've been putting electrodes in my brain. The voices are still there bothering me. I've had it. I can't stand this anymore. I would like to pull the plug in some way. So that is somebody with an actual psychotic diagnosis who may still be decisionally capable. Somebody who's saying, I have rapid cycling bipolar disorder. I remember a patient on the seafloor sitting with the resident with me and saying, look, you guys are great. You've tried everything in the book. I have had episode after episode after episode of mania and depression. I've been in and out of your hospital 20 times. I can't stand it anymore. It's miserable. Someday I may kill myself, and it's not your fault. It's just that this illness is debilitating. I can't take that anymore. So the question is, if somebody has rapid cycling bipolar illness or chronic schizophrenia, are they ever capable of saying, you know what, I'm still a human being, and this sucks, and this is really bad, and I would like to just kind of get out of this, thank you. I don't think we're going to have much trouble with the bottom one, which is if somebody has a treatable, reversible psychiatric condition, and we're attributing the wish to die to actually be a symptom of that condition that we can do something about. That we can do something about is really an important issue when you think about futility in medical care. Because the definition of futility is we don't have anything to do for you. It's the treatments that are futile, not the person who's futile. So if treatments are futile and we're going to beat you to death and we're going to bother you and we're going to, we can charge $300 million in end-of-life care, but you're not going to be any better and you're not going to feel any better and you're just going to be inexorable, are we doing you a favor? This is, oh, what the hell, 2 out of 3 ain't bad. Terminal case, unlikely to last 12 months, and of sound mind. Those are the 3 criteria that most states are using now to determine whether somebody can receive end-of-life care and medically assisted suicide. And I'm not advocating for medically assisted suicide. That's not where this talk is about. That's a different talk and it pushes the envelope even further than I'm going. What I'm talking about is just respecting somebody's opinion that their life is miserable and they may want to end it. So now more personal reflection. What determines how you in your offices sitting with a patient will respond to their request for you to just understand that they want to die and not jump in on them? Well, you have your own personal philosophical beliefs. Since the time you were a kid, you may have been raised in a religious community, in a religious school, whatever it is, you can't let people die. You have your own emotional biases. You have your knowledge, which we find is an epiphenomenon in a lot of this. And then you have these guys looking over your shoulder. So there's guilt and there's shame. And looking over your shoulder is the guy on the 6th floor who runs risk management. Okay? And the patient's lawyer, or the family's lawyer, and people from your medical group who'll say, you let the guy die? How could you do that? So it's all of these kinds of social pressures, peer pressures, or as Kate's brother Max said, you get a lot of pure pressure. And so we have all of these kind of things that are haunting you in your own decision making, and winds up with this: supporting the right to die. At least you're honest. He says, I support the right to needlessly suffer. And you have physicians who are just pushing it and pushing it and pushing it, and who are not accepting that there can be a good reason for a patient to decide not to live. So then the next thing is, why don't physicians always act in the best interests of patients? At least not going along with what patients say they would like to do. And there are all of these issues: professional reputation, legal actions, and financial conflicts. So we don't make a lot of money from dead patients. We turn that over to somebody else. And there are health systems that make a lot of money by end-of-life care. A considerable portion of the American medical expenses occur in the last 3 months of life. So we have to think about all of these issues. And there are different kinds of courts. So some of them will hold you accountable, or the family can really get to you if somebody commits suicide and they're unhappy about it. Even if they're happy about it, they can still get to you if they figure that you have deep pockets. Haven't seen too much of this. This is managed care. See the difference with fee-for-service practice and managed care. So, you're in your clinical situation, how would, and you have a patient who comes in, and I'll tell you about some who say, I'm going to die. I would like you to help me. You don't have to give me any medication. I just got those in Tijuana. But I would like you to spend time with me. I'd like you to talk to my family. I'd like you to get them on board. I'd like you to help straighten out all of these complicated arrangements I have. Will you do that? That's the question. Will you be an agent in my departure plans? If the patient says to you, I'm good with this, and everybody in my family is good with this, you're not going to have any problem. It's all great. How would you respond to that patient? Think about it for a minute. would you be saying, okay, I'll go along with it, we'll help, and so forth? The next thing is the patient is competent, has a good story, makes a good case, but says, the problem we're going to run into is my wife. She really, really can't stand the idea that I might die. And I'd like you to talk to her, but she may not go along with it, but I would really still like you to help me. And the wife has a litigious streak. How will that impact your own perspective and your own behavior with this? Let's say you were recently sued for not hospitalizing a patient who was suicidal, so you already have a little PTSD. Or you work for a hospital system where there's a lot of strong feeling about you don't do this kind of stuff. You don't help people to die. There's no such thing as assisted suicide and so forth. Or you know that your risk management office never backs anybody up when they get sued. They always blame you. Or somebody upstairs, you're not in this department, but your chairman or your supervisors are likely to micromanage and second guess you if there's any embarrassment of any sort. So will that impact how you are as a physician? And here are the kind of conflicts that we find ourselves in as clinicians. Autonomy versus beneficence. Are we paternalistic? Do we take charge? Do we tell people what's good for them, even though they are decisionally capable, autonomous individuals? Or do we say, you're right, this is your life, and I have to go along with what you want? How much of the obligations that you have are to the patients themselves or to the people who will be their survivors? Again, and they may not be on the same page. And what are the relative harms to survivors of experiencing and enduring the aftermath? Now, here are the words. We're going to start to get into Wittgenstein and deconstruct words and see what the emotional impact of language is in this whole business. So, your dad killed himself. He suicided. Or he had a passing. It was the right thing. It was sort of the passing that we could all go along with. So we're going to think outside the box. And here are the traps in which each of us exists in contending with thoughts about death. Way beyond medicine. I mean, you're starting to get into the words, what is psychopathology and what isn't. I can tell you, having played with the DSM for decades and watching how sausage is made, meaning how definitions are made for DSM diagnosis, there's a lot of sausage making. And, it's sometimes psychopathology is in the eye of the beholder and the name caller. What do we mean by psychodynamics, which you can kind of play any way you like? There are legal, cultural, historical, anthropological, all of these kind of things that play on what we do about death, how we think about death. Is Soylent Green, the movie that many of you have seen, an acceptable way for a society to go? So again, deconstructing these ideas. I study the theory of relativity, and I study the relativity of theory. And the idea of the relativity of theory is that there's a lot of wiggle room in any system you think about. The most orthodox religions have wiggle room that will allow you to die as a martyr. What's the difference between martyrdom and suicide? Wiggle room of all kinds like that. So, now I'm going to ask you this. Have you, in your life, had discussions with anybody in your professional life or personal life who wanted to really talk about their death and what to do and what role you should play and what role they should play? Healthy families are able to do this. A lot of families cannot come near it, and it just happens. It sneaks up on them, and nobody is sitting down to do arrangements ahead of time. Where do you want to be buried? How would you like us to take care of things? What do you want with this, that, and the other? And to really work out the details of end-of-life decision-making. Have you ever been asked to help somebody die? We have, Eileen and I, in our own personal life, a couple of times. Relatives, people with terminal cancer, people with terminal misery, with pain, with anguish, not with cancer. I will not tell you what we've done, but we've generally been helpful. And have your own attitudes and practices about this changed and evolved over time? If you're young, you say, I don't want to have anything to do with this, we're going to go gung-ho and save lives. I gave this talk to a group of distinguished leaders of the American Psychiatric Association, average age about 80, and they were all into it. Every single one of them said, this is where it's at, and this is where I'm at, and this is what we have to be dealing with. And I didn't feel this way when I was 40. I remember in the mid-1980s sitting on this stage with the guy who wrote Final Exit, the Hemlock Society fellow who's living in Santa Monica. And we had a debate. Walter Winslow was the name of the guy on the faculty who was a PhD ethicist. And this was a panel on Winslade, sorry. This was a panel on assisted suicide. And I remember being vehement, we can't do that, we shouldn't have a role in this isn't nice. Now, I don't know whether it's age or cultural shift or what, but my own attitude about this, as Obama says about marijuana, evolved. So things change. So here are death semantics. What words would you like to use when your patient wants to die? Is it suicide, killing oneself? And every one of those is going to elicit a different thing in your own RDoC system. Your own negative valence will be charged and stimulated in a different way depending on which of these words you use, down to controlling your final destiny, self-deliverance. I decided I'm going to use pre-planned death. Pre-planned death is an interesting way to look at things because you pre-plan everything. You know, you pre-plan your wedding, you pre-plan your retirement, you pre-plan your insurance. Pre-planning is good in this culture, isn't it? Think about it. I mean, you do pre-plan and you get extra points for pre-planning. How many people would like the opportunity to pre-plan their death? Just like the opportunity to do it. I see a hand in the back, and there are some more hands coming up. And I didn't even ask for a show of hands, but it's a moving kind of thing. People would like the opportunity to pre-plan their death. The building that we live in has some very, very wealthy elderly couples. And we've had this kind of discussion with them. And Eileen, somebody said, oh, what's Joel going to talk about at UCLA? And she told them pre-planned death. And this 91-year-old woman who owns an oil company says, oh, yes, we do that very well. So it's something that's sotto voce. And if you don't know what sotto voce means, please ask Ken Wells. So now, what roles are we being asked to play as professionals? to actually do euthanasia and assist somebody with suicide. There's a whole spectrum of behaviors that clinicians can play in dealing with people who are going to be pre-planning their death, down to acknowledging it, condoning it, just sitting there and saying, I got it, I understand it, I'm not going to get in your way. Don't ask, don't tell. Those are avoidances. Or, I understand that you're going to do this, and I'll talk to your family. Or, I might even be around if you need me. I'm not going to do anything, but maybe I could sit in the room while it happens. So, whole spectrum, and you have to ask yourself as a clinician, which, if any of these, are you comfortable with? Where do you draw your own line? Where does your boundary come up? It says, despite the defense attorney's creative wording, it was murder, not involuntary assisted suicide. So, but sometimes you need a little help. Okay. So now I'm going to tell you a little bit about Roger, who is a guy I treated for several years on the seafloor in the 80s. Roger was a brilliant, totally narcissistic CEO of a company with a PhD from Yale, came out here to run this successful company, and this was in the mid-'80s, and he was having the time of his life in the gay community, and said to me when we started to, he came for treatment for his irritability and rage because he had been abused by priests as a kid, and that was really what we were working with. And he says to me, Joel, don't be surprised if during the course of treatment I get AIDS, because that's how I roll. I mean, he had a very promiscuous lifestyle. He and his partner had an open relationship. They both knew that this was likely to happen. And he said, I'm going to tell you a story. He said, when I got out here, one of my friends was the regent of the University of California, and he had a dinner party. And the dinner party had 12 people, 2 of whom are still alive, because everybody had AIDS and everybody died of AIDS. This was the 80s. Here's the hospital where it was described. And he said, right now, I have friends who are up on the 10th floor. I don't know what the floor is in Ronald Reagan, but the 10th floor was the kind of concierge floor, who are dementing and emptying their bladder, and I'm not going to ever, ever, ever be in that kind of a situation. He said, if I get HIV positive, when it happens, I'm going to kill myself. And don't worry, I'm not going to use your medication. So he was reassuring. So we do work. About a year later, he says, I'm HIV positive. I'll go as long as I feel I'm okay. He starts to get sicker and sicker. And he said, I think the time has come. And I'm going to have a party. So what he did was spent $25,000 of 1989 money on a fabulous party with invitations, with the best champagne, great catering, invited everybody to his house. There was probably 100 or 200 people. He invited me and Eileen. I said, I just can't do this. He said, because what the announcement said was, this is a goodbye party. And you're going to come, and we're going to have this fun thing, and I'm going to have a chance to say goodbye to everybody. At midnight, you will go home, and I will be dead by the morning, because my partner is going to do a final exit with me. I met the partner and his executive secretary several times before the party, to plan them, to kind of help them through it, to let them think about it. And the thing that I couldn't do was attend the party. I just couldn't bring myself to do that. But certainly help with the preparation. And he set aside some money for me to meet with them in postvention after this happened. So I met with them, and they were fine with it. They missed him. They mourned him. They were not conflicted about helping this guy who was a control freak of his own life and everything else to go out the way he wanted and not to be demented and to not have a loss of dignity. This was patient number 1. Here's the name of the book. It has it's Manualized Psychotherapy for Death. You want a book and you want a protocol, you want algorithms, there it is. The next person I'm going to talk about, do you know where you're sitting right now? This is the Louis Jolyon West Auditorium. So I'm going to talk about Louis Jolyon West, who is one of the more important people in my life. He was chairman here from 1969 to 1990. Hired a lot of people here. Some of you knew him when you were residents. Some of you had to go introduce yourself at graduation. He was kind of larger-than-life character who was absolutely fabulous. Jolly had the misfortune in his 70s of developing a rip-roaring metastatic cancer, primary unknown. His wife, Kay, who many of you worked with, who was important to all of us, who was a wonderful psychologist, developed Alzheimer's disease, and she was dementing at that time. And what Jolly did was he got his son, John, to do an assisted suicide with them. First with him, and then with Kay. But they did it quietly and with the curtains drawn, because Jolly was very afraid that if this came out, John could go to jail. So they weren't taking any chances. Very few people on the faculty knew about that. I remember seeing Jolly here. He was already sick. He was sitting right there, and I think we came to say goodbye to him. There was almost like a festschrift for Jolly. Nobody was invited except for Joe Yamamoto, who was, one of Jolly's oldest, dearest friends, who knew what was going on. And they were in Jolly's house north of Sunset. And this went on, and John did, with Jolly's urging insistence, a final exit with him, got over that, and Kay, who was really dementing at that time, but it really made her own wishes known that she also wanted to die, especially if Jolly died. And he went and he affirmed with her that she still wanted this, and then he did this with his mother. I don't know how many of you have seen the book. John wrote this book called The Last Good Nights, Assisting My Parents with Their Suicide. For those of you who knew Jolly, who want to know about the history of this department a little bit, this book is really a very a last gift in some ways. And here are a bunch of other people who I've cared for, who've asked for help in their dying. There are people on this faculty who had pancreatic cancer, who took control of their own life and went out very fast, some of whom were at the VA. There are organizations to help people think this through, to help people with protocols. There's something called Compassion and Choice, which is a very big national organization. It's something to think about if the idea of pre-planned death and control of one's own final exits matter to you. If the idea is that if you can't take pills or don't want to take pills or don't want to get into trouble by going down to Mexico and getting barbiturates and then not being able to get through the wall, people can just stop eating and drinking. And it's known that it's kind of what people do on hunger strikes in prison when they want to die. And it's something that the organizations will at least inform people about. This is an option. You really want to die, you'll be out in a week or 2 weeks. Should assisted suicide be legal? Now again, this is beyond what I'm talking about, but increasingly people are believing that assisted suicide makes sense for some people in some circumstances. Psychiatry is number 2 on the list behind emergency medicine. By country, as you can see, the United States is lower down in the pack, but in Belgium, the Netherlands, this is a lot of this going around. The morality of it, and a lot of people say, look, if you're suffering and there's no chance, there's no hope, it's moral to do this. Younger people are better with this than older people. So there's a cohort effect, that is the demographically younger cohorts can see assisted suicide more readily than older ones, and Democrats a little bit more than Republicans. So I figured out a way to get around the doctor-assisted suicide taboo. My living will directs that in the event I'm terminally ill, suffering 6 months to live, you're to put me in a dog costume and take me to the vet. And the purpose of this is we are kinder to our dogs and cats often than we are to our humans. So, what's it going to take to have pre-planned death accepted by society? I think it's going to take a church that sort of embraces it and ritualizes it, and kind of the more of that then you're going to need music, and then you need a caterer. So you can get some of this, some of this. If you want to go out high end, you can do it in Switzerland in sort of suicide hotels where you go and it's 5-star, whatever, and get a cocktail that you can have at some point. And there are sort of regulations for these kinds of practices with suicide tourism. You like that? What are we going to say? It says, assisted suicide is just not natural. And you have the guy in, 43 different tubes. Boy Scouts. There are groups that are really advocating, sit down and have the conversation with your family and have everybody together. And with that, I will stop. A couple of minutes for questions, comments, or whatever else you like.
Hi, Joel. It's Doreen Seidler-Feller. It's good to see you again. I'm here.
Ah,
You're looking right at
yes.
me. My question to you is this. Do we have any data on the PTSD reactions of those who assist with suicide. What do we know about the after effects of physicians, psychiatrists, psychologists, and other professionals who are put in the position
Yeah.
of assisting
Yeah.
in any of these ways, regardless of the semantics,
Yes.
but with the act in some active
Yes.
way? Do we have any research?
I'm not aware of any study. I think it's an empirical question. I also think that there is a spectrum of temperament in terms among physicians, so that there are some physicians who will never be able to do anything like this. They just can't do it for the reasons that I mentioned, their own personal, emotional, temperamental, whatever. And there are other people who say, you know what, I am a midwife to death. That's my role as a professional, and I can do this and be helpful. And if you take a look at people who work in hospice, many of them do. One of the reasons that I just got involved with my 3 newest best friends, who are these young palliative care physicians, is that they were caring for some women with terminal anorexia nervosa in hospice, and said, you know, this really upset me. I take care of dying patients every day. I take care of patients with cancer, but I didn't know how much of this was willful, how much of this I should have jumped on and let go, and yet this person clearly wanted to die, had been in and out of treatment for decades, and so I did it, and yet I feel conflicted. I don't know what's going on. So one of Yager's rules is if something bothers you, the way you cope with it is you write about it. And we're starting a group to actually try to flesh out some of the emotional stuff that goes on in palliative care physicians who are trying to deal with non-cancer patients or people who might have psychiatric disorders who wind up in palliative care and who die. So the short answer is we don't know. The second answer is I suspect that there are some people who will do it a lot better than others, or who can't do it at all. But that's true of anything in medicine. I mean, when you know, I can't be a neurosurgeon. It's never going to happen. I have 2 left hands, whatever. So some people will do it, and not everybody should do it. If you know that this is not for you, you should not do it. I think the principle, though, is to be honest with patients and say, you know, this isn't my thing. I'm not able to do it. If you are really determined, I will refer you to somebody who I think is a colleague of mine who might be able to do this for you. That's different. Otherwise, what you're doing is you're imposing your own legal, moral view on somebody else's decision where they may have autonomy and be decisionally capable. So even in the assisted suicide literature, the assisted death literature, Linda Ganzini, who's one of the people in Oregon, who's one of the leaders in this field of trying to study the psychological reaction to dealing with people who are meaning to die, and many others in that field will say, if you can't do it, but you think that this is a decisionally capable person, you should be trying to find others to whom to refer. The way you were, if you say, look, you know, you need a certain procedure that I can't do, you need ECT, I don't do ECT, I'm going to refer you. Same thing. Yes? Okay. Miriam.
Yes, Joel. Hi, Joel. It's really nice to have you back after, I don't want to tell people how many years, right, since medical school.
Yeah.
Anyway, my question is, what if someone does have made all the preparations and wants to, you know, kill himself and he's terminally ill, and then he's unable to do it because he has some cognitive impairment?
Yeah. I think.
What happens then?
Yeah. I think at that, the question is, if somebody wants to do it but can't put the pill in their mouth. I mean, this happens not infrequently with people with ALS. I mean, this is really a very interesting and unsolved issue right now. So there are some people who say, I'm going to write out instructions authorizing somebody, when I blink 5 times, and that's all I can do, that I want you to give me this stuff and try to get somebody who's going to agree to do that. We have a friend, one of Eileen's friends, who had absolutely god-awful diabetes, rheumatoid arthritis, lupus, and was an osteoporosis, had no skeleton, pain up the gazoo. She lived in another state and wanted to find somebody to help her to exit. She said she put up with it for years and years and years and said, I can't do it anymore. Found a physician who said, I just can't do this, but I know somebody who's going to help you. And they found somebody who had a helium tank. Helium is a way to go. And she had her friends come into the house. The helium therapist came in, had a mask on, and instead of filling up balloons, he filled up her lungs. And within a couple of minutes, she passed. He took the helium, disappeared. The friends did what they were going to do in terms of wrapping up the household, all prearranged, and nothing shows on post. So this was another interesting way of exiting, all prearranged, and she couldn't have done it by herself. She said, I don't have the strength, I don't have the ability. So there are ways in which you do it. Could this guy wind up in jail? Might. It was a red state. Thank you very much.